malfunction, or in other words pacemaker syndrome, which is a clinical syndrome. Incidence of this varies from nearly 10 to 30% post implantation of a pacemaker.
Malfunction and syndrome are same.
No, malfunction is multiple other syndromes also. We are talking about particularly pacemaker syndrome. Otherwise, malfunction will include atrial capture mismatch or non-capture, non-sensing, multiple things that we are not going to discuss because that's a vast topic. So before going to malfunction or pacemaker syndrome, we'll discuss how to approach for evaluation of any pacemaker malfunction post implantation of pacemaker. So first is symptomatology. This is must. Patient may complain of fatigue, confusion, dyspnea, dizziness, chest pain, palpitation. Common causes of these symptoms are sensing abnormality or capture abnormality. That can be further assessed on ECG and interrogation of pacemaker. Another cause is pacemaker syndrome. Particularly in pacemaker syndrome, patient complains of fatigue, confusion, dyspnea, orthopnea, pre-syncope or syncope. That we will discuss why and how.
You can add convulsion as well.
Yes, yes. So that are all medical causes that will come in a focus history. Then suboptimal rate modulated pacing also can cause this kind of symptoms. Second common symptom, which is not very common, it will come maybe in 1% of patients post pacemaker implantation, that is hiccups, and that is due to diaphragmatic stimulation. If your RV lead is implanted at the apex, then it is irritating the diaphragm, then patient will complain of hiccups, that is diaphragmatic irritation, and it will be because of LV pacing due to phrenic nerve or RL pacing close to phrenic nerve, RL lead displacement and going into SVC, or lead perforating and going directly onto the superior surface of diaphragm. Then chest wall or pectoral muscle contraction, that is also more or less similar. If your pacemaker output is quite on higher side, like more than 5 millivolt, then patient can have chest wall irritation or prepectoral muscle contractions. Lead insulation is damaged, then again the current will pass to the chest wall and patient can have this kind of symptoms. Lead perforation and directly going onto the anterior surface towards the pectoral muscle can also have this kind of symptoms.
Regarding the symptoms, these symptoms are somewhat LV dysfunction like that.
Yes, yes. So
But
pacemaker
these
syndrome is
symptoms are not particular regarding the.
So pacemaker syndrome is basically LV dysfunction only. And why that will happen? Because of atrioventricular dyssynchrony. That is pacemaker syndrome.
The point is that patient, when patient comes, pacemaker and patient comes to us, should we suspect in all patients that these symptoms are always due to patient?
Yes, suspected. Yes, always. Although there are differential diagnoses are always there, like coronary artery disease, LV dysfunction. So you can go for further evaluation, ECG and echo at least.
My mind is this: clinically, is there anything we should suggest? No. Clinically, this is patient.
No, clinically not only clinical. ECG and echo is must at least. If not pacemaker interrogation, ECG and echo is must. Pacemaker interrogation will sort out majority. Second is focused history. That is also very important. Like what was the indication for pacemaker? Whether it was EV nodal dysfunction or whether it was complete heart block, whether it was second degree EV block. Because this is also important. That also I will come to in later slide why it is important. Second, what was implantive operative reports? Whether there was any difficulty in implantation, where was the lead implanted? Because these things like diaphragmatic irritation and anterior chest wall irritation, you will come to know only while you know the site of the implantation of the leads. Then medical and cardiac diagnosis, what was the diagnosis, what was the LV function that time and what is LV function now? What medication patients on? Sometimes this could be a side effect of some medications also. And history of recent medical procedure. Then device history. This is just to complete the approach. That is date of implantation, pacemaker generator, what is manufacturer, what are the alerts or recalls which would be received by patient, spatial features, lead systems. On physical examinations, always look for signs of heart failure because that is pacemaker syndrome. It's a type of heart failure only. Canon A wave in JVP. Canon A wave occur in JVP when atria will contract against closed atrioventricular valve. So what happens in pacemaker, like somebody is implanted a single lead pacemaker, VVI pacemaker, then atria is absolutely independent and ventricle is being paced by pacemaker. So ventricle will pace at the rate of 70 or 80, whatever it was set, and atria is contracting at the rate of 100, suppose, and there is AV dysfunction. So atria sometimes it will contract against closed atrioventricular valve. So there will be cannon AV in JVP if it's a single lead pacemaker or some pacemaker malfunction. Pectoral and intercostal muscle stimulation has to be checked. Put your palm on the chest and you will also feel that there is some abnormal activity going on. But this is also nowadays it is very rare. Previously it was common when the previous generation of pacemaker were being implanted, then it was common. Otherwise now it is very rare. Inspect for pocket site carefully. Many times pocket infections are also there. Then comes the ECG for sensing and capture abnormality. X-ray for lead position and gross integrity of leads. Although the discontinuation or breach of insulation cannot be seen on X-ray, that has to be seen on either interrogation or that has to be predicted. And then finally is interrogation of device that can be done by this company. So this was the case which was 86-year-old woman presented with 6 months history of severe peripheral edema and work limiting breathlessness. So basically she was in NYHA class 3 to 4 dyspnea. A dual chamber pacemaker had been implanted 12 years earlier for complete heart block, and she had recently been prescribed amiodarone for paroxysmal atrial fibrillation. Previous echo had demonstrated small hypertrophied LVV and diastolic diameter of 3.9 cm and good systolic function, normal systolic function. So why this lady went into this failure kind of thing? Recently only change was description of amiodarone. Now amiodarone per se cannot cause heart failure. So this was the ECG. I'll end up this. This was the ECG. So this first bit was sinus bit. There was fever followed by pacemaker spike and capture of ventricle. Then this
side, when this was not AV pacing or it was only ventricular.
It was dual chamber pacemaker and it was on a demand mode. Whenever it is required, it was generating the pulse. So this first bit, the P wave was native P wave, followed by QRS complex which was paced. QRS is all paced, all QRSs are paced. Here there was atrial capture, atrial spike, followed by P wave, followed by QRS complex. So this was dual chamber pacing in same patient. This is all in same ECG. And here there was atrial capture, atrial spike, no P wave. So this was loss of atrial capture. Why? Probably because of amiodarone. The threshold of atria is increased. That's why this atrial lead is not generating any fever. Or maybe because of atrial fibrillation, aging process, the atrial threshold is increased. So basically in this case, if we increase the output from the atrial lead, it will capture atria, it will contract atria, so atrioventricular synchrony can be again established and this kind of symptoms can be elevated. Yes, definitely. We will require diuretic for this. We will require ACE inhibitor for this. We will require echo for this patient to rule out any other etiologies like ischemic heart disease or development of some mitral regurgitation. Because this kind of symptom will again come because of mitral regurgitation and LV dysfunction also. So let's go to the initial history. Then only we will come to know what happened. First, this was pacemaker, initial pacemaker in 1920s and 1930s. By Mark Lidwell, 1928, Australian anesthesiologist who implanted pacemaker in children who was born with a complete heart block or in a flatline state. Then Albert Hyman modified this pacemaker to artificial pacemaker, but these are huge machines which was kept outside the body. 1940 and 1950s physiological simulator came into picture like this, and by 1970s pacemaker designed by Zoll. This was a pacemaker. Patient has to go ahead with pacemaker which was not implanted inside body, wires were outside. So this is like external pacing. Then in 1958, first implantable pacemaker was invented, and first surgery was done on this person, Arne Larsen, by Dr. Seni and Runa Elbquist. This pacemaker, first pacemaker lasted only for 8 hours. After that, they required change of generator. Fortunately, this person survived up to 2001 and required 5 lead changes, 22 generator changes. So 22 time battery replacement and 5 time lead replacement. But it was successful throughout.
What was the age when he was implanted?
That was 1958 to 2001.
There are any age here?
And he died at the age of 86. So it was somewhere in his 30s and 30s.
Young.
And he had basically CHP with this intermittent CHPs. So since the first pacemaker, investigator has noted since then that decreased cardiac output is the response to ventricular pacing. Why decreased cardiac? Why that is always known that AV dysynchrony, atria is not contracting, ventricle is contracting in VVI pacemaker type of thing particularly, or atrial lead dysfunction. Then there is atrioventricular dysynchrony, and as we all know physiology, atria nearly contributes 25% to cardiac output. If this 25% cardiac output is lost, definitely person is going to end up with decreased cardiac output. And with this decreased cardiac output, aortic and carotid baroreceptor reflex activity will also increase, and that will increase total peripheral resistance to maintain blood pressure. But in some patients, like in elderly or in diabetics, this total peripheral resistance does not increase in response to cardiac output. That will lead to reduction in blood pressure, and this is basically a pacemaker syndrome.
So on echo of such patients, their cardiac output is reduced. What will be the changes in ejection fraction?
Ejection fraction will remain normal, but here LV filling pressure like diastolic dysfunction will increase. Ejection fraction will remain normal throughout. Or maybe patient will develop some mitral regurgitation, which was not there previously. Patient will develop even mild mitral regurgitation, or from mild mitral regurgitation to moderate mitral regurgitation.
Filling pressure will be increased or decreased?
Increase. It will increase over a period of years.
Initially you will find low filling.
Initially nothing. Initially echo will be normal.
So filling pressure will be low.
Low.
Because
initially,
the filling of LV is low.
Yeah. Initially
So
it will be low.
Yeah.
It will be low initially. So this decreased cardiac output, loss of atrial contribution to ventricular filling, loss of total peripheral resistance response, non-physiological pressure waves, this will contribute to the syndrome collectively known as pacemaker syndrome. And nowadays many authors have suggested this as a AV dysynchrony syndrome rather than calling it as a pacemaker syndrome, because it is not per se because of pacemaker or pacemaker malfunction. So they say it is a AV dysynchrony syndrome. This was also described way back in 1970s. In 1979, pacemaker syndrome term was coined. By 1994, Forman redefined pacemaker syndrome as loss of AV synchrony, retrograde VA conduction, and absence of rate response to physiological need. Now, what is importance of discussing VA conduction? Because even if patient is having complete heart block, atrioventricular node is in complete block, still VA conduction can remain present in nearly 30% of CHP cases. So that's why it is important to know whether patient was in CHP, second degree AV block, first degree AV block before implanting pacemaker. If there is first degree, second degree AV block, chances of VA conduction present is nearly 70 to 90%. Even in complete heart block, VA conduction will remain present in 30% of cases.
Seriously?
Even if the AV node is totally closed. So, for example, if your definition is it is a disease that represents the clinical consequences of suboptimal atrioventricular synchrony or AV dysynchrony regardless of the patient mode. So, what example we had seen, that was dual chamber pacemaker. There, because of amiodarone, atrial threshold is gone up. So, even with dual chamber pacemaker, patient can develop this syndrome, although it is very common with VVI kind of pacemaker. Incidence in different studies, it is somewhere between 10 to 30%. And Sulke and Associates showed that 75% of patients who were satisfied with VVI pacing benefited from upgrade to DDD mode pacemakers. So it is always easy when patient is having VVI pacemaker, develop this kind of problem, upgrade to dual chamber, patient will improve. Pathophysiology that we have already discussed, loss of heavy synchrony lead to decreased cardiac output. VA conduction, that is again VA conduction is non-physiological conduction. And per se VVI pacemaker is also non-physiological because our mode of contraction or transmission of electricity is from AV node to the Purkinje fibers. That is from upside down. While in VVI pacemaker, the VVI pacemaker is generally implanted at the apex. So now transmission of the electricity or cardiac current generation is from apex to base, that is from down to up. And our heart, this is not a natural, this is non-physiological. And even in physiology, when you look at the heart will contract like this. Now because of contraction at the apex, it may contract like this or it may not contract at all. It will just contract like this. So this is again non-physiological method that will lead to decreasing ejection fraction over a period of time. So this VA conduction is non-physiological. Again, it is delayed because it is in a reverse manner, and it will generate decrease in blood pressure in response to ventricular pacing because of AV dysinterest. This is same apical RV pacing, reverse contraction. Suboptimal atrioventricular timing can also hamper atrioventricular synchrony. Loss of atrial peak. Atria nearly contributes 20-25% to cardiac output, and when atrial peak is lost, there will be a decrease in cardiac output for sure. Atrial contraction against flow strike a speed valve that we discussed in canon A wave. It will lead to raised JVP and patient may complain of headache, cough, jaw pain or claudication of the upper extremities. Elevated LN-RA pressure will lead to symptomatic pulmonary and hepatic congestion, and high level of atrial natriuretic peptide because of dilatation of atria will lead to vasodilatation throughout the cardiovascular system. The risk factors are that more or less we have discussed, but peri-implantation period risk factor is low sinus rate, high programmed lower rate limit, like sometimes the ventricular is programmed at the rate of 80, then this kind of chances are more. Post-implantation, VA conduction is present then yes, but if I say this VA conduction can be managed easily, if you increase the atrial rate, if you increase the ventricular rate in a dual chamber pacemaker, VA conduction can be managed very easily. Underlying cardiac condition in patient is having diastolic dysfunction to start with before implanting pacemaker. Patient is at high risk of this kind of syndrome, cardiomyopathies and non-compliant ventricles. So pacemaker syndrome can result from any pacemaker mode. Particularly, it is very common for this kind of PPI pacemaker when atria and ventricle is contracting separately. And here, if we look at this negative wave is a reverse P wave. That is a PA conduction. Here also, after ventricle, this P wave is being generated. This is VA conduction, typical seen on ECG also. So, if this kind of ECG is there, and patient complains of symptoms like early heart failure, this can contribute to this pacemaker syndrome. So signs and symptoms are very vague. First is heart failure, dyspnea, orthopnea, PND, edema, low cardiac output state with present as a fatigue, weakness, lethargy, dyspnea, particularly female, generally female will present like this. Unexplained weakness, unexplained dyspnea, lethargy, LV ejection fraction normal. Then hypotension that will lead to mental state change, diaphoresis, signs of orthostatic hypotension, neurological symptom because of the congestion of the HPC, that is dizziness, near syncope, confusion, seizures, hemodynamically pulsation in neck vein and abdomen because of this atrioventricular dysynchrony and canon A waves, choking sensation, jaw pain because of fullness of HPC, right upper quadrant and headache pain, and very rarely palpitation. Differential diagnosis multiple. All needs to be ruled out. Acute coronary syndrome, cardiogenic pulmonary edema because of LV dysfunction, carotid sinus hypersensitivity, which is very rare, not common. Medical hypothyroidism needs to be ruled out because many of hypothyroid syndromes are also overlapping. Hyperthyroid syndromes are also overlapping. Pacemaker malfunction in terms of lead capture failure or sensing failure, and pacemaker mediated tachycardia. Pacemaker mediated tachycardia is again separate topic, but in short, it is a end of pacemaker syndrome. When pacemaker is getting, battery is getting depleted, patient will start having tachycardia circuit. Because
once the symptoms are general examination done and you have taken ECG, how many diagnoses will be ruled out?
ACS will be ruled out. Carotid sinus hypersensitivity is already there. Hypothyroidism can be ruled out because patient many times complains of excessive feeling of cold or excessive feeling of hot. So that can be ruled out on a clinical examination. Only thing you will require to rule out is echo to rule out mitral regurgitation and LV dysfunction. Otherwise, from ECG, majority of thing can be ruled out. And if you have this kind of ECG, you are almost certain that this is pacemaker syndrome. Treatment is more or less supportive treatment for heart failure, hypertension and oxygenation deficit. For patients with VVI pacemaker, we need to add atrial lead, upgrade it to DDD pacemaker. Or if patient is in DDD pacemaker, go for interrogation. Check whether it is AV synchrony, and we can change the mode or we can change the setting and go for again asynchronous pacing. For patient on other pacing modes, we can, these are very technical things like hysteresis, AV delay, P-valve, sensing level, that can also be checked and that can also be changed.
Now the pacemaker with some autophagy, the way
Here, it will come, it is DDDR, that is rate responsive pacemaker. Whenever patient is walking and the requirement of heart rate is on higher side, pacemaker will detect it with that patient is walking and pacemaker will increase the rate. It is also possible, that is also advanced mode. That's why this syndrome is nowadays not very common.
And now most of the time which kind of pacemaker are you using? DDT?
We use DDD, DDDR, both.
So means that having problem like this could be.
We have, because in this Yojana patient, we use VVI pacemakers also. Nowadays we have stopped doing it, but in past we have done VVI pacemakers. And at many centers, like particularly in government center, many people are doing VVI pacemakers. So other than nothing, something is always better.
Yes.
How frequently you will find incidents of supraventricular arrhythmia in patient on dual chamber pacemaker?
Very rare.
Very rare, right? But unfortunately, if he develops, then will you add any anti-arrhythmic?
You are right.
Okay, then there will be a risk of this thing again.
Yes. But that is an elderly, like this patient what I showed, that was 86-year elderly. Otherwise, amiodarone per se, to certain extent, yes, it will increase threshold. It is anti-arrhythmic drug. It has to increase the threshold. Then only arrhythmia will terminate. But not always. It's also very rare again.
But suppose if a patient is dually paced and unfortunately atrial fibrillation or SVT happens, what effect will be there on ventricular rate?
See, it will not increase because upper limit we have already set. Even in rate responsive pacemaker, upper limit of 100 or 120 we have already set. So it will not go beyond that. But when SVT is there or atrial fibrillation is there, atrial fibrillation forget it because atria is not going to contract. So there is no chance of AV synchrony or anything. Atrial fibrillation is its own problem. But say SVT or say atrial tachycardia, where atria is contracting at the rate of 200, so there will be AV synchrony because ventricle upper rate is already reached. And pacemaker will not allow it to go beyond 120 until unless AV node is conducting at the rate of 200.
So can't we do anything with dual chamber pacing only to control that rate?
No.
No?
No, that has to have an ICD function or something like that. If it is dual chamber ICD, we can do something like we can give anti-tachycardia pacing. What is anti-tachycardia pacing? Atria is contracting at the rate of 200. So temporarily ventricle will contract at the rate of 300 or more than 200. And think that if it's a re-entrant circuit will break and physiology will take
So that
place.
is AICD, not pacemaker.
That is an AICD.
So if upper limit is already fixed, then it is possible that patient will develop SVT.
No.
If it is already
it is
fixed,
natural
it is less
process.
likely to develop.
It has nothing to do with this. This is hypothesis.
Yes,
Like not SVT. Atrial tachycardia patient can develop with age. Atrial tachycardia, atrial fibrillation patient can develop. Or very rarely, when AP node is totally gone, patient is in CHP, but there has to be some accessory pathways which will get activated in future. Very rarely SVT is also possible.
So primarily, if atrial tachycardia happens, we need to correct hemodynamics more. That is why it is needed.
Yes.
Otherwise, it was fine. Whereas
Yes.
ventricles upper limit is set, there won't be any issue, right? But probably some symptoms, and because of the loss of atrial kick, that is what we are trying to achieve with this, right?
It's true. Yes.
What are the anti-arrhythmic choice for in such patients?
If atrial fibrillation, amiodarone, definitely.
Yeah.
Or high dose beta blockers can be given. See, there you have to decide whether you are going for rhythm control or rate control. If atrial fibrillation is new, you can go for rhythm control, like amiodarone. If atrial fibrillation is chronic, persistent, atrial tachycardia is persistent throughout, no need for any rhythm control. Go for only rate control with either beta blocker or lactic acid.
Fine, persistent atrial tachycardia, you will always put AICD rather than pacemaker. Simple, isn't it?
Yes. But anyway, from many times what happens after implanting pacemaker, the patient will lose to call. Suddenly they will come after 4 years, 5 years. So at least go for pacemaker introduction, you will come to know what
What's
thing is
going
happening
on.
in how many years.
That is always it.
Can we give cardioversion in a pacemaker patient?
Yes, we can be. We
No
can be.
issue with the.
No
It
issues.
will not interfere with the.
No issues. If at all there is an issue, you put a magnet mode on. Magnet will convert any dual chamber pacemaker to VVI pacing. Then you can cardiovert, and later on you can again switch them on to DDD pacemakers. Even in AICD also you can cardiovert, no issue. AICD anyway, you don't need to cardiovert because AICD from outside will give cardioversion. But one condition is there where you need to cardiovert in AICD also. When patient is having this ventricular VT stop, ventricular tachycardia. If you will allow ICD will keep on giving shock. But VT storm is like 3 shocks more than a day, and patient will develop this kind of storm. Then if ICDs keep on giving this shock, battery will get depleted within 2 years or within maybe 2 months also. So in that case, you put a magnet on ICD, switch off the ICD with magnet, ICD will go in switch off mode, PO mode, or absolutely switch off mode. Then you treat from outside and then again restart ICD. Otherwise, there is no logic behind changing battery every 2 years or every 6 months. So VT storm, yes, this is one condition where you need to give external shock in ICD patients also. So prognosis is very excellent. With correction of pacing mode, this can be managed easily. This is one more thing, pseudo pacemaker syndrome, which was a point recently. Similar kind of syndrome or similar kind of AV dysynchrony in patients who are not on pacemaker. So AV dysynchrony outside setting of pacemaker is with this kind of symptoms is pseudo pacemaker syndrome. Extremely prolonged first degree AV block can have this kind of syndrome. Nodal rhythm more rapid than atrial rate. AV node is firing more than the atrial rate. Then again there will be dysynchrony. So these are two things in which pseudo pacemaker syndrome can be also possible. This is also very new term. Nobody is using it. So this was all about, in short, about pacemaker syndrome. Pacemaker malfunction we have not discussed. If you always, we can discuss in some other lecture because this will be a lengthy lecture, maybe for 1 hour or so.
Another article.
That is it. But if you are looking more of pacemaker ECGs in your clinical practice,
Nobody looks
then we can discuss.
કરવા માટે જ
Yeah.
તો પેસમેકર અત્યારના સમયના હોય તો CT MRI કરી શકે.
MRI compatible to carry say majority of pacemaker nowadays is partial MRI compatible at least. Partial means you cannot go for chest MRI, brain, leg, you can go for
But
it.
go for 3 plus Tesla, no issue.
3 plus Tesla needs a full pacemaker compatible, full MRI compatible pacemaker. Less than 3 or up to 3.5. Partial, yes.
Most of the pacemakers are
Most of the at least partial compatible, at least. And more than 3 Tesla in Baroda, no need to worry. Go for MRI. It's okay.
3 ટેસ્ટ લાવડા કર્યા ને.
એટલે તો no need to worry about it. You go ahead with MRI. Partial compatible છે. Only thing is that after implanting pacemaker for 3 months, better to avoid MRI. At least up to 3 months. Even if it is fully pacemaker MRI compatible, then also up to 3 months.
Why?
Because lead can get disturbed. Even with a certain amount of MRI or magnetic waves, lead can get disturbed. So up to 3 months it is not required, not advisable until it is life saving.
CT is okay.
Okay, thank you.